Welcome to Marney Reid Presents Connect to Develop, where we provide insight from healthcare leaders on the hottest topics and trends. Listeners, I'm really excited to introduce you to 3 early career all-stars representing different practice models for our discussion about how and when to incorporate something new into your practice. We have Dr. Lizzie Lieberman, hip and knee replacement surgeon at Clinical Associate Orthopaedic and Fracture Specialists in Portland, Oregon. Dr. Carl Herndon, assistant professor at the Department of Orthopaedic Surgery in the Division of Hip and Knee Replacement at Columbia University Medical Center in New York, New York. And last but definitely not least, Dr. AJ Rush III, orthopedic spine surgeon at Texas Spine Consultants in Dallas, Texas. Hi, folks.
Hi, Marney.
Hey, Marney. Thanks for having us.
Yeah, Marney. Thanks so much for having us.
Very exciting to talk to you 3 today. So to set the scene for context and relatability, I'd love to start with Lizzie first, and I'd like to have each of you share a little bit about the type of practice that you joined, more about your subspecialty, and how to set existing protocols were at your practice or institution when you got there.
Okay, so I'm currently in private practice. It's my second year with this group. It is my second job out of training. It's a 20-surgeon orthopedic-only private group. We have a partnership with a hospital system that we work with and operate out of a single hospital mostly. We also own a surgery center. I have 3 other partners who do predominantly hip and knee replacements. So basically 4 of us doing very similar things. When I joined this group, practices were pretty set up for me, meaning we have good joints protocols for our hospital versus ASC setting. And I was able to just kind of dive in and piggyback on what my partners were already doing.
Sounds great. How about you, AJ?
Yeah, thanks again for having me, Marty. Yes, I'm at a spine-only private practice, kind of one of the bigger markets. And so when I joined, everyone's a spine surgeon and kind of many people have the same protocols, but I was eager to kind of continue something I had early adopted in fellowship, one of the new enabling technologies, augmented reality. And so that was something that was relatively new, both to the market and really to the, spine world at large to some extent. And so that was something I wanted to implement because I just felt that it was kind of a gateway to make us a little more efficient. And I think, the outcomes I had seen in fellowship made me think that the reproducibility of that was beneficial for workflow. And so it was something I wanted to implement early on. And so kind of, talking about hurdles and things that might come about when you're trying to implement something new, especially a capital equipment expense as a new young surgeon where not everyone else is using that. There's definitely hurdles to jump. I mean, you kind of have to convince people of the value add. And sometimes these things are seeing as believing, and it's hard to show people something that doesn't currently exist. But luckily, I was able to kind of rely somewhat on my previous mentors and some of the data we had collected during fellowship, as well as kind of collaborate with some of our industry partners in terms of demonstrating value to both the hospital. And I think showing that the capital cost is kind of the economics of it are reasonable, and we were able to kind of push that through and get it done. And that was something that now has, I think paid dividends in terms of, continued patient outcomes and as well kind of positioning the hospital to some extent as a branding component for them to be like a spine center of excellence sort of situation and kind of a leader in terms of enabling technology and kind of the future of spine care. So it was successful and continues to be.
Thanks so much for asking, Marnie. So I am in academic practice in the Northeast. I did what Lizzie did with her first job. I went back to the institution that trained me for residency. And so I was well familiar with all of the protocols that were in place. Obviously, my mentors and attendings that taught me in residency are now my partners. There were some things that I wanted to do differently, though, both from a patient care perspective, also from a training perspective as an academic surgeon training residents and fellows, wanting to be able to train them in some different techniques and different methods and stuff like that. And so when I was coming back, was pretty clear and upfront about some of the things that I was hoping to do in terms of approaches and tables and stuff like that. And so that was some of the main stuff. In terms of some of the other protocols, like post-operative protocols and multimodal pain regimens and things like that, fortunately, again, being at an academic center, everyone's very interested in, maintaining strong evidence base and everything else like that. And so most of that was fairly well optimized, and I was able to just adopt the practices of my partners and just sort of get in and hit the ground running.
Let's keep with Carl. Can you give us an illustrative example of a protocol or system? You say, techniques. I assume these are things that you learned in fellowship, but can you give us an example of something that you implemented when you got back?
So one of the things from ease of surgery and a chance to train trainees and everything else, and something that I got out of my fellowship that I didn't get any training on in residency, was the direct anterior approach to the hip using a specialized table. Most of my mentors do an anterior-based approach of one kind or another, but they use a standard OR table. And I got a chance to see the other side of the coin, the anterior approach with a specialized table in my fellowship. And so I wanted to bring that back. I wanted to be a little bit different again, from a trainee perspective, to get folks a broader breadth of training. And I also just found it to work really well in my hands, and it flows really nicely. And I feel like I'm able to do the case, reliably and predictably and reproducibly using the table. And so that was one particular thing that I wanted to make sure that I had access to when I returned.
Can you talk about key stakeholders? You said that, you kind of put expectations up front. Walk us through the process. And did you begin it while you were in fellowship? I mean, how did you get it set up so that coming into practice, it was available for you? Or did you have to wait a little bit and, do some cases and then get it in?
So I had everything set up before I got there. So my first case in practice was more or less how I wanted to do things. Obviously, every time you start on your first day of practice, or I'm sure Lizzie can attest to on your first day of your new practice, everything's going to be a little bit different than you've ever done it before. It's a different OR, it's a different staff, it's a different set of retractors, even if you've gotten a chance to, preview some of that stuff. So what I did was I stole all of the preference cards of my fellowship mentors and more or less tried to recreate the way I did a hip based on how one of my fellowship mentors did a hip, using the table and using some different retractors that weren't available and things like that. And so after I had already signed my offers, probably 4 or 5 months before I was set to start my job, I got in touch with and sent an email to the hospital to talk about what trays were available, what they had, and then sent the preference cards of the surgeons that I was trying to emulate down to them, and basically tried to sort of come to a consensus about, what I felt like I wanted them to buy for me that they didn't have, and they didn't have something that was more or less equivalent. What things I was willing to compromise on and just say, okay, I don't need that thing and I can just get over that. And then what they already had that was similar enough to what I was asking for. And so we went back and forth, and it wasn't necessarily a negotiation, but just sort of an open conversation about this, that, and the other thing. And we literally had a shared spreadsheet that looked at the SKU numbers and everything else. And they had a team look at sort of things that were equivalent and things that they thought that they had that might be equivalent, that some of them turned out to be just fine and some of them turned out to be absolutely not the same. And so went through each of those items. And then I moved to the city that I'm practicing in, obviously, before I started practice. And so I also took some time with my implant reps and also the hospital again. I went to CSPD, a couple weeks before I started, just to make sure that they had everything in stock that we had discussed, and sort of walked through a case, not in the OR, not with a patient in front of me, but it literally, downstairs in the basement where they clean instrument trays, and just in my head, asking for each instrument, making sure that they had some version of that, or it was what I expected. And there were still adjustments that needed to be made and everything else, but all of the things that I felt like I needed to have there to be able to do good surgery and take care of patients, I wanted to make sure we're all there starting ready to go day one.
I love that visualization. And I know Lizzie does some great talks about how surgeons can prepare physically and mentally like athletes. Lizzie, when you went back to your institution after your fellowship, was it a similar process since both of you started off in academics?
Yeah, actually really similar. So one thing that was very helpful starting my first job, so just for context, my first job, I was hired by the place where I did my residency. So Oregon Health Science University, but I was operating at a satellite hospital, essentially. So it was a small hospital, no other surgeons doing joint replacements. Prior to me getting there about a year earlier, somebody had retired. So they had stuff to do joint replacements, but not the specific things that I knew or needed. I had never set foot on campus with the exception of an interview prior to taking the job. I didn't know what the operating rooms were like. So before I got to my job, I had reps actually from my area come and visit me in my fellowship. They did a wonderful job of borrowing the cards that Carl's talking about and helped put together some trays with things that were already existing at my new job, as well as there were a couple of instruments that I wanted specifically ordered to add to that. I actually had them bring sawbones in. So when I got back to Portland where I live, I was able to go and do kind of a run through just using sawbones. And, whether or not I actually made the cuts, I don't even remember, but just to have my hands on all of the instruments. And I had a brand new PA who I didn't know hadn't worked with either. So that was very, very valuable. Again, like Carl said, just making sure you don't show up for your first case without the tools that you need in order to be successful. So I found working with reps was one of the biggest things that was quite helpful in making sure that I had what I needed. It's just another person double checking. They know where things live. They know who to talk to in different hospital settings as well. So you mentioned earlier, Marnie, talking about stakeholders. It's really important to know who's the right people to go to ask for the things that you're looking for. And so having reps help to get you coordinated with the purchasing people or the OR nurse or one of the surgical techs who's like the lead for orthopedics, they kind of know what's there, what's not, and can help you purchase whatever you may need. I will say too, one other thing that I felt was helpful for me personally was, having watched a couple of people start off practice, I think some people come in and they're asking for the moon. They're asking for millions of dollars worth of things right out of the gate. And I kind of got a little bit of a lay of the land and figured out what was there before I asked for everything, especially the more expensive things. And I thought that gave me a little bit more credit when I then did say, hey, you know what, we really do need to consider getting a robot or purchasing another HANA table, things like that.
Lizzie, I totally agree with you about using your vendors to help you. So any listeners right now that are in training, particularly fellows, particularly second half of the year fellows, think about how you're, as you're being trained and, what implant system you're going to end up using, whatever. Obviously, it's fairly rote for Lizzie and I as hip and knee surgeons. We do right hip, left knee, left knee. But I also had my anticipated chosen vendors come and visit me in fellowship. They came to the OR. They saw the trays that we were using. And every regional place has their own sort of funny nicknames for instruments and stuff like that.
Oh,
and
yes.
So that thing is called X in Charlotte, but might be called Z in St. Louis and might be called A in Portland. And so you have to be able to sort of know the lingo also. And so it gives them a chance to understand what you're asking about and what you're talking about when you're asking for whatever the thing may be.
I like that you had a spreadsheet with SKU numbers and everything. I recommend also taking pictures. Oftentimes, if you didn't have the foresight to get that SKU number or whatnot, which, that's a lot, and fellowship is a very busy year, or if you're, suddenly changed practices, but at least having a picture of something, a lot of reps, to your point, or even ortho techs or spine, techs can look at something and go, oh, you mean the such and such. AJ, as someone who's not just doing a left or a right hip, there's a multitude of different types of spine cases. How did you in advance work on this? I really liked the story that you told about how you figured out how it could be a win for the hospital, wanting to bring in.
Yeah, I think it somewhat echoes what Lizzie said. Obviously spine, tons of random instruments. And as Carl said, everything's named something different. So I kind of echo what they said that, work with the local reps in your fellowship and your residency, be close with those people. And you can kind of get that information and, pick around what you like, right? I mean, they work with different surgeons too. So you don't have to just use what that one fellowship director or mentor did. You can kind of mix and match as you please. I think something to add that I found helpful, because I did the same concept, taking some pictures, writing some SKU numbers. Maybe I'm more of a personal relationship kind of guy or whatever, but I was pretty close friends with like the OR director at my fellowship and in my residency and had their number. And so even when right before I left and even after, if I had realized I forgot something, they actually were really reasonable and easy to deal with in terms of sending the pick lists of some of my mentors. And, luckily with those, they're very specific and they're the actual name of the instrument with, again, usually the SKU number or something. So it's very easy for someone to figure out because, I think especially for spine, like sometimes it's something as specific as just the draping method. You get somewhere new and you've been doing it so much at your fellowship or in your residency that you don't realize that the first day it's on you, they're like, oh, by the way, what kind of drapes do you want? And you're like, I don't know, the drapes, like I have all these crazy instruments and this Kerrison number or whatever, but I don't know the drapes that we use. And luckily with those pick lists, even the most simple mundane thing that I think some of us take for granted are always listed on there and very specific, and OR staffs around the world can kind of interpret that. And so I think that was super useful. In terms of, the kind of capital equipment stuff and tools, I totally agree with Lizzie. I think you don't want to come in and be asking for the moon. I mean, I tend to say a Kerrison's a Kerrison. And so what I really did is when I got to the places I ended up, I, walked the SPD area with one of the nursing staff. And, if they have something even remotely usable, I think it's probably better to, come in easygoing and see if you can, to some extent, make it work as long as it's within the realm of something you've utilized, than it would be to ask for some crazy custom instrument that's going to cost them a ton of money.
So as someone who came in to a very busy spine practice, one of the nice things that Lizzie had going for her was there weren't a bunch of other hip and knee surgeons where people could say, yeah, but so-and-so doesn't need that or doesn't do that. You came into a very robust spine practice. What were any political nuances or, things that you had to navigate from senior partners, especially if you brought in technology that they were not using?
Yeah, you got to be tactful. Obviously, you don't want to, come in saying like, oh, I do it differently than so-and-so, especially if they wrote the book on that procedure. In some scenarios, that was the case in my situation. But, I think to some extent, that's probably where personal brand comes in, right? Like I at least try to do more minimally invasive surgery. And so I think if I was asking, and again, this scenario didn't always happen, but if I was asking for something more specific, it might be tailored toward an MIS approach. But in general, I think actually it's really just collaboration. I mean, a lot of times if there was that kind of situation that arose and so-and-so uses X, I would take a look at it. And, if it seems that it's something that I could utilize, maybe give it a shot before I go and throw an instrument across the room and ask for my toy, because I really think that most of those things work. And the time where I think it's different is if it truly is some sort of very procedurally specific, technique specific instrument. And that stuff is usually assisted, at least in spine, by the industry representative. Anytime that if it was a true instrument that was needed in a very specific setting, like a special lateral retractor or something like that, that's where I think relying on the industry reps is probably easier to circumvent that awkwardness, because they would just bring that thing in that's specific for that procedure.
I like the collaboration and leaning towards others too. Were there any specific people, well, let's roll that back. Were there any people that if you could go back and do it again, you would thought, wow, this person really, either was a champion and I wish I would have brought them into the process sooner because, things might have been easier. And in the inverse of that, are there any people where if you forget about them, they could be a huge roadblocker to getting that new protocol adopted or that new technology that you need?
I think it's probably institution specific, Marnie, but I think in general, the chief of the OR, which has a different title in every different place, whether that's the chief nursing officer of the OR, because all of this stuff has to be handled by them, opened by them, and that kind of thing. The head of CSPD or instrument sort of management. And so they're going to be the ones that are looking at the trays, what's in the trays. For instance, like one of my trays that I was trying to create an efficiency tray and just combine two trays into one tray, but it was too heavy. There was a weight limit on the tray because, people got to lift these things up and move them around or something every day. And so anyway, so that person was a key person. And then for the bigger like capital purchases and things like that has to go through, again, every institution is a little bit different, but in our institution, that's another person, another team of people that does sort of large procurement and evaluation of sort of bigger ticket items.
I think Carl is really hitting the nail on the head saying it's so situation specific, but also mentioning that every action you take has a huge ripple effect. So even if you think, I'm just doing this thing, I'm just asking for this different instrument, I'm just trying this different protocol, there's so many people impacted by everything you change, every decision that you make. I think it's important to know that you're not reinventing the wheel with any of this. And so the biggest people that I think I have always regretted if I don't involve early and often would be my partners or other people who work at the hospital. So starting out, just not having as many orthopedic partners. Well, there's general surgeons there. There's other people who have gone through the process of trying to get something new or trying to make a change. So asking for advice from people who have probably already gone through a similar situation to you, I think is the best way to kind of get the lay of the land and figure out who you're going to need to involve in each scenario. It's also looking at what's motivating people. So when you go to the person who is looking at the numbers and the money and the bottom line, maybe that's not the first person that you take your big ticket item to right out of the gate. They're going to give you an immediate no if they don't see the return on that investment. They're just going to be looking at the immediate numbers. So I think you kind of got to play your cards a little bit depending on what the ask is and go to different people in different order. So you really load the boat with people who are supporting you before you ask the wrong person.
Yeah, I think echoing what Lizzie just said, and it kind of hit the nail on the head, collaborating with partners that do something similar to you, and even reaching out to people that maybe aren't necessarily in your practice. And this is somewhat, hospital dependent, but a lot of hospitals have people from multiple different places working. And I think, if you can get a team or a group of surgeons, like now all of a sudden it's not just one person asking, it's an entire entity. And I think one way that I found that bridges that, again, probably goes back to the industry connections that some of us have. Like my particular rep or company might also represent other surgeons, even in the hospital, that I'm not aware of because I might operate on a different day than them. But I think they can sometimes, be like, oh, actually, that surgeon is also asking for something similar and, can help, I would say, that collaborative method. And similarly, scrub techs and things like that, even the small, very random kind of people might be able to connect you with someone else that has a similar request or is, having a similar struggle. And then there's definitely power in numbers. And I think that's a really powerful way to, get your ask across without also kind of crossing the line and being some sort of at least perceived as, needy or, difficult, right? Because you're really just trying to make everyone work better and have a better overall operative experience and therefore patient outcome.
Did you pick anything up since you got back from fellowship, either based on, some studies that you saw or anything that you decided to implement into your practice? And if so, what parameters were you using to judge why and when and how you adopted that into your practice?
I might be to hit that one first. Yeah, I think like one of my fellowship mentors had some famous quote that I always butcher, but essentially it's like if you're still doing it the same way you learned in fellowship, you're probably not improving. And I think, that resonates always, right? If we're not trying to change what we're doing to be better, then you're really not advancing yourself in the field and your own practice. I think that comes more to like what you hear at conferences and kind of anecdotal experience from more senior people or kind of experts in the field or people that you look to as mentors, even in early career and later on. And I think implementing that stuff actually is probably easier because then you're known at the hospital, right? You have a little more say in your practice or in your facility. And I think, people have seen you be successful. And so if you come in asking for something, this person means business, right? They're helpful. And obviously there's the financial component that, we provide to our practices and the hospitals. And I think they're aware of that now that you're not like the newbie on the block. And I think it becomes a lot easier actually to implement those things than it is probably fresh out of the gate, both from ourselves being a little bashful in the beginning, but also the hospital or practice you're with not really knowing you completely well. And so not, you're kind of betting on a horse you don't know versus, somebody that's more tried and true.
I'll just share my experience. So I came out of fellowship right in the middle of COVID. So my fellowship was 2019 to 2020. When I started practice, I, again, was at a hospital where we didn't have a great same-day discharge or outpatient program set up. So all of my patients were spending the night in the hospital. I didn't want to get that going too much until I was through boards. I just felt like it was rather risky and something that if I didn't need to, I wasn't going to start this new protocol that nobody had done and everybody was nervous about. However, we kept getting shut down because of a variety of reasons that were mostly COVID related, but we were short on nurses or we were short on anesthesia, or either way, the only way I was going to be able to do cases is if I could figure out how to not have patients spending the night in the hospital. So I had to figure out how to start a safe same day discharge. And to do this, I had meetings every other week with people who I identified as stakeholders. I brought research papers to the table and showed different ways that people had implemented programs such as this. And I involved the patients as well, saying this is something that we're doing that's new. We welcome your feedback, and, really got buy-in from all of the stakeholders. We were hugely successful. And one of the things that I did was also record how successful we are. So everybody was able to kind of celebrate, hey, we just discharged our 10th patient same day. They were in the hospital for a total of 6 hours. That's so awesome, everybody. The first patient, it took 10 hours to get them out the door. Look at the progress we've made. So getting the stakeholders involved, getting them bought in, and then celebrating successes, short and long term, with them was really, really helpful in bringing something that people were pretty afraid to begin to do. But I'm super proud of how we did it. And actually, there's still a surgeon doing joint replacement there and doing a lot of same day discharge with the protocol that we started.
That is incredible to hear. I love enlisting the patients too in advance. I hadn't, ever really thought about that.
Yeah, I mean, especially for something like that, if they didn't know what was going on, they'd be like, why are you trying to kick me out of the hospital? Or some of them, they had one side done and you're going in to do the other side. Well, this is different. Yeah, it's new, exciting. We're trying something different. Please let us know how it goes. We want to make sure we're safe. We've been really working on this program and you get to be a part of it. And actually, it's funny because I got some great patient reviews out of that as well. You don't realize that your patients are really bought in this and they want to see you getting better. Like AJ said, if you're doing the same thing, you're not getting better. Even watching professional basketball players, why do they continue to practice? Why do they change their free throw if they've been doing it for so long? Because there's always room to improve and get better.
I love that. Carl, anything you've added?
The big thing that I added or changed was I changed vendors, I don't know, maybe 8 months ago or something like that. And so that was a switch for a handful of different reasons, but made that decision. And so that was a sort of a new change. But in terms of adding new tech or anything else like that, I'm still young enough in practice that I have not rated all that much yet.
Yeah, I like what Lizzie was saying, that segment where you're in collections. I didn't understand it as a rep, and it wasn't until I started, building out programs specific to the subset of, residence fellows and early career that I really understood and appreciated how critical that board collection time is. And, not wanting to make, any big adjustments or changes, if at all possible, until, you submit for that and then sit and pass part 2. Can you actually unpack that a little bit for us, Carl, just so that people out there who maybe don't understand the early career surgeon subspec truly appreciate? In fact, all of you, I'd love for you to weigh in. What is at risk if a surgeon changes anything in that collections period?
So I guess 30,000 foot view, you finish residency and you sit for part 1. So that's a big standardized test. Assuming you pass that, you then have 5 years to sit for and pass part 2. Most people in the U.S. nowadays do at least one fellowship. So you do your fellowship year, you get your privileges the following fall. You have to have privileges before November 1st. And then a 6-month period in your first year of practice. As of this year, they moved up the window, and so now it starts January 1st. You collect every single case that you do as the primary surgeon. You need to do a minimum of 35 cases in that 6-month period. And over that 6 months, there's a online website where you have to enter what you did and why you did it, and a little bit of basic patient information and those kinds of things. And then the following fall, so you're now 1 year into practice, you have to finalize that whole list, pay some money, and send that to the board. The board then thinks about it over the winter, and then 3 weeks ago for me in my class, they send you back out of the however many cases that you did in that 6-month period. They send you 12 of them. And so for those 12, you have to go back in and collect all of this data, all of their hospital notes, all of their imaging and x-rays and everything else like that, and basically submit every shred of evidence and justification for why you did what you did, if there were any complications, what happened, how you handled them, how they turned out, all of those kinds of things. And then July of your second year of practice, everybody goes to Chicago and you have to defend those cases in person. Then you find out if you passed in September. And so that first 2 full years of practice is incredibly stressful for young surgeons. Obviously, all the things we're mentioning here, you're moving to new cities, you're moving to new hospitals, you're trying out new things, you're all of a sudden the attending and not the trainee. It's a lot of stress happening. And then on top of that, you know that there's this big governing body that's going to be looking at all of your cases and going through it with a fine-tooth comb and making sure that you were doing the right thing and that you had the appropriate indications. And if there were complications, and there always are complications, what you did about it. And anyway, so that whole experience makes people very wary of doing anything that is new to them, because they want to just continue to do the thing that they know, that they've been trained to do, that they feel tried and true with, because they want to try to avoid as many complications as possible and don't really want to go outside of the bounds of, appropriate indications for surgery and things like that.
Is robust, to say the least.
Yeah, that was a great overview. I mean, that is in a nutshell.
I'm smack dab in the middle of it at the moment, so...
That's a tough place to be, Carl. And trust me, it gets better once you're on the other side of things. And I'm sure you'll do very well because you're conscientious. But I think, for young surgeons, the whole point is that we're just trying to make sure that people are safe. And one way that you are safe is by mastering kind of the basics first. So I think that's where people who come fresh into practice and start doing consulting things and working with industry and bringing in new technologies or trialing some new implant, that's where you could kind of run into trouble. People who do things that have questionable indications, I think, are just going to be under a microscope a little bit differently by these board examiners who tend to be just a little bit more conservative in terms of how we indicate patients and operate on people, because until you have the benefit of experience, it's hard to really push boundaries, I think, too much in your practice. So we come out of all this training and want to dive in and start changing the world, but they're just trying to make sure that people are safe and ease into things, master the basics first. So I think that's where just being a little bit conservative in that period comes into play. And that's true for things that you do in the operating room, how you indicate patients, and things you do outside the operating room, with different protocols and things, even down to like the antibiotics that we're giving patients, things like that. It's not the time to tell everybody that, this brand new study came out, I don't need to give dental prophylaxis anymore. You don't want to be an early adopter or the first adopter of anything new like that until you've at least passed your boards.
Absolutely makes sense. This has been a wonderful discussion. Before we sign off, your final 2 to 3 tips on anyone who is looking to implement a new protocol. Doesn't have to be whether they're an early career surgeon, but maybe wants to try something new on, the process and what to look out for and best practices.
Yeah, I think bottom line, obviously, it needs to be something that, has true value and you're truly passionate about. People read between the lines. If you're just kind of, trying to sell some industry something or, try something new for one day for fun, that's probably not the right thing to be asking for. But I think, if you get buy-in from colleagues, from your practice, from local staff members, and you get assistance from industry reps and kind of the hospital staff. And again, every place is so different in terms of who you really need to talk to. But I think if all those things are in place, right, it's good for the patient. It's something you believe in. It's something that's actually going to be a value add either to your practice, to your outcomes, to your patient satisfactions, to the hospital satisfactions, or obviously for some of these bigger expenses, maybe to the hospital bottom line. I think if it's checkbox of all those things, people are going to want to have that. They want to be, every place wants to be on the cutting edge. And if you're going to champion that thing, you're going to be successful with that. And I think it would probably be a good thing to try.
I'll say, just reiterate what AJ said, that I think the first thing that you have to evaluate is, does this help patients? All the other things that he mentioned are 100% true. We live in the real world, and you have to think about the bottom line, and you have to think about market share and marketing and advertising and whatever else. But does this new thing that I'm evaluating answer a clinical question or solve a problem that actually exists? Is it going to help patients? And is it going to help me do my job better and give patients better outcomes. As long as the patient is your true north, I think that's the thing that gets you through a lot of those other doors. And because by keeping that patient as your true north, you end up automatically checking all the other boxes anyway. And so as long as you're actually answering a clinical question that exists in your mind or solving a problem that exists in your practice, I think evaluating those kinds of things is absolutely reasonable. And then all the other things that AJ said are 100% true too, making sure that you have buy-in from all of the stakeholders, making sure that you've evaluated it sort of from all sides of the dice so that you can confidently go into that meeting or send that email or make that phone call and ask for whatever the thing may be.
Can I jump in for one thing before we switch to the most important person at the end, Lizzie? I didn't comment a heavy amount on that boards component, but I think it goes back to what Carl just said, and it kind of ties in here. I mean, I absolutely live by what you just said. I mean, everything has to be patient true north. And I think somewhat for the early career people, especially in board collection period or whatever, Lizzie and Carl painted a scary picture. And obviously I would say the same. Boards, as we were talking about it before this call, super intense and scary. And, you don't want to rock the boat. And I think if you keep that mentality that Carl just said in terms of the patient being number one, is the indication correct? Is what you're doing for the patient in their best interest? And have you kind of considered every other alternative? It somewhat fits the same profile. And to some extent, I agree, you shouldn't rock the boat and do something fancy or brand new during your board collection period. But I think, if it's something that's truly superior for the patient and there's significant evidence to support that, if that's at the heart of what you're considering or doing, I mean, it's pretty hard for a board examiner or anyone to kind of say that wasn't the right thing to do. And obviously you can't do something that's not proven, but I think that mentality, if everyone leaves this podcast with one thing, that statement was just epic.
I guess I'll end with my 3 pieces of advice for anybody who's trying to introduce something new. I would start off by saying, make sure you do your homework and get a lay of the land. Know what protocols and practices are in place before you come in and try and disrupt everything. And know the history in terms of what's been tried prior to you bringing in something new. Number 2, set a wide radar. So if you're going to make a wave, know that it's going to have a ripple effect, and make sure that you kind of cast your net to figure out who may be involved in that ripple and get them involved, get their buy-in, and continue to keep them involved throughout the process. And then number 3, follow up and constantly check in with how things are going. And most importantly, don't be afraid to change course if something isn't working. So if you invest a ton into starting some new protocol, bringing in a new technology, or trying something new, it's not always going to work, and nobody's going to fault you if you can put your tail between your legs and say, you know what, I'm sorry that I tried this thing, but it's just not working out. But if you keep trying to push and make something that's not working work, you're going to be way, way worse off. So be willing to admit if something's not going as you anticipated.
Phenomenal advice and tips from the 3 of you. Well, thank you so much for your time, your candor, and I look forward to the next discussion.
Thanks, Marney.
Yeah, thanks a lot, Marney.
Appreciate it.
Thanks for listening to Connect to Develop. You can find more interviews and Marney's Minutes on my YouTube channel at Marney Reid Presents.